Good morning, Cyprus, and good evening, down under in Australia. How are you? Thanks for joining us, everybody, and we hope you're all safe and well. And welcome to the COVID-19 Australia-Cyprus Forum, being organized by the Australia Alumni Association of Cyprus and in association with the Australian High Commission in Cyprus and the University of Cyprus. A warm welcome and heartfelt thanks to our distinguished guests who we will be presenting in a few minutes. Guests from Australia, Professor Alan Cheng and Dr. Stefan Herodotou, and from Cyprus, Dr. Constantinos Tsioutis and Dr. Nicholas Tsioutis. Cleo Givas, the Secretary of the Association, will be joining me to present and introduce the speakers as we move along. First, let me tell you a few words about the association. The association is a voluntary organization. It was established back in and registered in 1998 in Cyprus. The aim is to bring together, connect, and support graduates from Australian universities now living in Cyprus. It organizes various scientific, cultural, and social activities in an effort to create bridges and establish links between Cyprus and Australia. Membership is open to any graduate from Australian university or tertiary institution. During the last year, we've been working on the establishment of a particular network, an online resource, a repository of activities, scientists, professionals, and organizations in Cyprus and Australia for the purposes of establishing, fostering, and nurturing closer academic, cultural, and business relations between Australia and Cyprus. We hope to be able to launch this project, which is very ambitious and a very interesting one, and we call it AUCYNet, OCNet, before the end of the year. And now the reason we're here. We've all had trying times over the last 2 years, and we still do in both countries and all over the world. All systems undertook and underwent a rigorous crash test. While people in countries were paralyzed and looked for something to lean on, the scientific community made unprecedented efforts to find the most effective means of combating this deadly virus. I'm sure you'll all agree that with those efforts that the scientists have made, that created stability and hope to see us through this crisis. However, some people and some leaders, some politicians went against this opinion of scientific community, as usual, disregarded scientific expertise and adopted reckless policies and behavior. I'm thinking, of course, of some leaders in the UK, Trump, the Bolsonaros of this world, and of course, the anti-vaxxers. So what have we learned from all of this in Australia and Cyprus? And what were the responses in both countries? How can the accumulated scientific research, evidence, data, and knowledge help us respond to the current challenges posed by the pandemic, in particular the Delta variant? How can we make effective use and good of the good practices of the evidence? I'm sure that our distinguished guests will address those questions and tell us about the immunization programs, the current situation in Cyprus and Australia, vaccines, and vaccination rollouts. So without further delay, let me invite Cleo Givas to proceed with the introduction and bring in our first guest.
Good day, everyone. My name is Cleo, and I would also like to welcome you to this forum. And of course, to thank all the participants for taking time to share their knowledge with us all today. Thank you. Before the experts on the subject take the floor, I would like to introduce to you Ms. Michelle Anderson, who is the Deputy Head of Mission of the Australian High Commission here in Cyprus. Ms. Anderson is a career officer with the Department of Foreign Affairs and Trade. She was most recently a senior analyst in the Global Watch Office. She has previously served overseas as First Secretary and Consul in Kuala Lumpur, and also served on missions to Port Moresby, Ho Chi Minh City, Phnom Penh. Ms. Anderson holds a Master of Business Administration from the University of New South Wales, a Bachelor of Linguistics from Edith Cowan University, and a Bachelor of Design from Curtin University. Miss Anderson also lives with her dog Peach, who is proving to be a popular diplomacy ambassador. Hello, Michelle, and thank you for being here with us today. And of course, we'd like to express our gratitude to everyone at the Australian High Commission for their ongoing support. The floor is yours.
Thanks, Cleo. Look, I'd like to say welcome to everyone to what has become, since the beginning of the pandemic, the new normal, the online meeting. Today's webinar comes at a critical juncture where Australia is now facing the lockdowns and curfews that we in Cyprus faced not so long ago. Despite these measures, both our countries have unfortunately seen hundreds of people succumb to COVID-19. So broad is COVID-19's reach. Not one person can claim that they have not been affected in some way by this historic event. We have witnessed across the globe frustrations of governments, people, businesses at the lockdown and restrictions, while equally witnessing the absolute heroics of healthcare providers trying to save the lives of their communities. In Australia, the Delta wave is growing at an alarming rate, and authorities are in a race to vaccinate the masses against it. In Cyprus, luckily, whose vaccination rates are already high, we're seeing the corresponding drop in cases. However, winter is coming, and as we have seen, waves come and go with each new variant. So today is a great opportunity to share best practices, lessons learned, to discuss the way forward and to speculate about what the future holds. I'd like to give a special thanks to our expert speakers today. Together they are part of a larger team of world-leading public health officials, medical researchers and science communicators that serve to help protect us from COVID-19 during this pandemic. But before I pass you on to the Cyprus High Commissioner based in Canberra, I'd like to thank the team of volunteers at the Australian Alumni Association in Cyprus for their innovative outlook and community spirit and for putting this event together. In particular, Cleo and Sarkis for their ongoing work building bridges between our two countries. They are the human face of our deepening and enhanced bilateral relationship. Thank you.
Thank you, Michelle. Thank you very much. And next up, we will have someone who has just joined us from Canberra. Hello, Martha. How are you?
Hello, everybody. Good afternoon from Canberra. I did hear Michelle, but I had a little bit of a problem to get connected. Not because we have a problem in Australia, it's me. I'm not very good with technology. I would like to congratulate you, Sakis, and the alumni for organizing this very interesting event tonight to talk about COVID-19. Let me just tell you that we are in lockdown in Canberra. And as most of the cities, we've been in lockdown since August 13, and it's going to be until October 15 for the good for all of us. And we are all following the rules and regulations of our state and our and on national wide also. And today, for you who don't know, we had an earthquake in Melbourne. Thank God we didn't have any injuries. Everybody seems to be okay. There was just a little bit of a damage. There were 3-4 aftershocks after that. And it's according to the reports, people should expect to have a few more afterwards. Let me just tell you, as far as the vaccines are concerned, you do know that Australia did ask the helping hand of the EU. Cyprus was very much willing to help because we do have this extra bilateral relations. Can you hear me?
Of
we
course.
Have this okay. We have this extra bilateral relations. We have the second biggest Cypriot community here in Australia, and of course we always appreciate the principal stance of Australia in the Cyprus issue. Unfortunately, of course, because we are a very small country, and they wanted more than 200,000 per country at least vaccines, the Pfizer. We couldn't because we didn't have any surplus in Cyprus. And as you know, we're also going to start having the third boost in Cyprus, but we did. We had all the willingness, so did the Ministry of Foreign Affairs and the Ministry of Health. Hi, Sam, I can see you too. Can see you now. I know you're doing an excellent job in Cyprus. So having said that, I would like to thank our speakers also, and we are very well waiting to hear what they have to say, our experts in Cyprus and in Australia. And let us don't forget that we have to follow their advice, because it's for the good of all of us, for the good of the whole world. So thank you very much for this initiative against Sagis, and I'm eager to hear what our experts have to say on the issue. So stay safe, sane, and healthy. Thank you.
Thank you very much, Martha. Thank you very much for taking your time. Cleo, the next speaker, please.
Yes. Up next is Dr. Ioannis Pneumatikos on behalf of the University of Cyprus. Dr. Pneumatikos is a graduate of the Medical School of Aristotle University of Thessaloniki. He has been a specialist pulmonologist since 1990 and an intensivist since 1994. He was a professor of intensive care at the Democritus University of Thrace from 2003 until 2020. And from January 2021, he's a professor of intensive care at the University of Cyprus. Welcome, Dr. Pneumatikos, and thank you for being here with us.
Thank you very much.
Good morning.
Good morning and good afternoon to all. Dear Australian High Commissioner to Cyprus, Mr. Samuel Beaver, dear Cyprus High Commissioner to Australia, Ms. Martha Mavromatis, dear friends at the Australian Alumni Association of Cyprus, dear speakers from Australia and Cyprus, and dear online viewers. On behalf of the University of Cyprus and the Medical School, I would like to welcome you all to this Australia-Cyprus COVID-19 forum, which we are delighted to fully support along with our partners. In the digital era of multi-information and over-information that we live in, it has been strongly demonstrated during the past year and a half that misinformation and disinformation grows and spreads nearly as rapidly as does a highly infectious virus during a pandemic like the one we experience. The role of clear science communication has never been more crucial than now at this time of public health emergency. This is why we strongly believe that activities and events like this one here are the most precious remedy against the fear and the anxiety that all people naturally feel at a time of public health crisis. Australia and Cyprus have a long history of collaborations and shared values. As our two countries confront this pandemic from a different viewpoint, the shared experience gained so far can only make us wiser towards the future. We look forward to hearing the speakers' presentations and have a fruitful discussion at the end. Once again, on behalf of the University of Cyprus and the Medical School, thank you all for being here. Thank you to the organizers and the speakers, and I hope you will enjoy this forum. Thank you.
We thank you, Dr. Pneumatikos, and let's start with our special guests from Australia. And first up, I would like to invite Professor Cheng. Professor Cheng, how are you?
Very good, thank you.
Good. Professor Cheng will be speaking on learnings from the second wave in Australia, the current challenges posed by Delta, and issues raised by the Australian immunization program. Professor is an infectious disease physician, director of infection, prevention and healthcare epidemiology at the Alfred Health, and professor of infectious diseases epidemiology at Monash University. For 12 months from July 2020, he was Deputy Chief Health Officer in Victoria, Australia. Additionally, he is a member of several government advisory committees for infectious diseases and immunization. Professor, the microphone is yours.
Thank you. Just checking that you can hear me okay and see my presentation.
Yes, we can hear you.
Great. Thank you very much. So thank you very much. And thank you to Your Excellencies, Mr. Beaver, Ms. Anderson, and Ms. Mavromitis. So Kalimera, Kalispera, to wherever you are. So just about me. So I am an infectious diseases physician. I work at one of the hospitals in Melbourne. And I'm involved in many of the government committees around immunisation and in the response to COVID. And until June this year, I was helping out as Victoria's Chief Health Officer for the state that I live in. I'm from Melbourne in the south of Australia. It's traditional in Australia to acknowledge the country on which we stand, and that for me, that is the Boonwurrung people of the Kulin Nation in Melbourne. And it's also important to reflect that Indigenous peoples in Australia are very highly vulnerable to infectious diseases and pandemics. And last year we had a great success in protecting them. This year it's been a bit more challenging. So Australia is a big place, and probably the best comparison I can make between Australia and Cyprus is that I understand that the size of Melbourne is about the same size in area as Cyprus, but the city of Melbourne has about 4.8 million people, Cyprus about 1.2 million people. We are obviously a very large island. To go from Cyprus to Spain is about the same as going to Perth, and Cyprus to Sweden is about the same as going to Darwin for us. So it's a very big place, and we have about 80,000 Cypriots in Australia, but we're a very diverse community. There are many different nationalities, as you can probably tell from me speaking to you. We have a fairly good public health system. It's a mix of public and private healthcare, quite strong laboratory capacity, and perhaps not quite so strong in the public health system. We had cases of COVID in Australia very early in the end of January. And part of that reason is that we are one of the top destinations for Chinese travellers, at least we used to be until all the borders got closed. And some of our other vulnerabilities are that Australia really functions like it is 8 separate countries rather than one country. We're a federation of states and territories, and some of the states like Victoria and New South Wales are quite large, but others such as the Australian Capital Territory and Tasmania and Northern Territory are much smaller. Diversity is a strength as well as a vulnerability, so we have to communicate to people in many languages, and there's different cultural issues that each group brings to the table. And I guess the first thing to say about Australian public health is that it's very complicated. So we have, as I said, we function like 8 different countries, and each state has its own chief health officer. We try and coordinate this through what's called the Australian Health Protection Principal Committee. And there are a number of other committees to try and coordinate responses through that. But each state has its own way of dealing with has had its own way of dealing with COVID, and notably we are one of the countries, one of the few countries in the world, or at least developed countries in the world, that doesn't have anything like a Centre for Disease Control like the European CDC or the American CDC. So we had a first wave in Australia in March last year, and as you can see, we closed the borders by the beginning or the middle of March, and then there was a lockdown that lasted about 4 to 6 weeks. And this was our really first taste at locking down, and that managed to suppress the numbers from a few hundred a day right down to almost nothing. Unfortunately, it wasn't quite nothing, and what we had in Melbourne was the outbreak began to emerge again in June as winter approached in Melbourne. And what you can see on the right here is the genetic testing. Each dot represents a different case. The yellow dots represent people coming in from overseas, and the black dots represent cases that were acquired in Australia. And what this shows, each of these horizontal lines is basically an outbreak, and you can see that most of the outbreaks had finished pretty much by May. But we had a small outbreak at a meatworks in June or in May, and then going into June. And then, unfortunately, we had these cases that escaped out of our hotel quarantine system, the Ridges Hotel and the Stanford Hotel. You can even see that these 4 dots are one family. It transmitted to one of the workers at the hotel and then on to the community. And unfortunately, this resulted in a very large second wave, about 20,000 cases just in one state, in Victoria. New South Wales had a few cases, that's the black at the bottom, but you can see that most of the cases were in Victoria towards August and September. And what we had really was this this intersection between high-risk settings and high-risk populations. And this is not to say that it is, you know, the personal responsibility of these people about spreading it. It is more that the situation that they find themselves in. So a lot of the people that work in hospitals and aged care and particularly high-risk workplaces like meat processing are people that speak many languages. English may not be their first language. Their understanding of the public health directions was lower, and also they were not able to stay at home. They can't work from home if you work in these settings. And some of these, or many of these people live in accommodation that is also conducive to the spread of infections, such as public housing and crowded situations, and also many had quite large households. So if we think about why people were not able to isolate or quarantine, they're the people that can't. They still require the contact with public, such as taxi drivers, many of the industries that have quite poor industrial protections, such as meat workers and food processing, and then those that work particularly with vulnerable populations, such as aged care. And I think many economies in the world have found this casualised workforce. Many people working across different sites might work across 2 different aged care facilities. And so the way that we tried to address some of these things was to have what was called pandemic leave. And I think these economic supports are probably some of the most important things that we did in Australia, to allow people to do the right thing by giving them payments so that you could support them while they're waiting results, or if they required quarantine. There was this scheme called JobKeeper last year that allowed payments while people were having to have stay-at-home restrictions that were imposed on the community. And then there were obligations put on the employer to do the right thing, to let people take leave, and employees to tell their employer that they had COVID or they were required to quarantine. So, and then there was a lot of things that we did learn. We are probably better now at engaging with the community and talking to people about COVID. We have a lot of support to try and protect the vulnerable settings, particularly aged care and high-risk workplaces. There was a lot of structural change about worker mobility, trying to get people to work at one place rather than working across different workplaces. And then we developed indicators to work out, you know, when might things be going wrong and we need lockdowns, and trying to respond a bit better. So things were going fairly well in Australia. We fought off this second wave in Victoria, and probably for about 9 months, we really didn't have very much COVID at all. A lot of those cases in between were overseas acquired cases. But then in June, New South Wales had an outbreak of the new Delta strain. The first case was a transport driver that transported international arrivals, and then it has spread to parts of Sydney. And similar to Melbourne, where the initial spread was in the outer suburbs, where it is hard to control it, and a lot of the community is a bit more disadvantaged. It was the same pattern in Sydney, where Western Sydney is the part of Sydney that is probably the most disadvantaged. And unfortunately, this has resulted in outbreaks in other jurisdictions in Australia. So to date, we have had just over 88,000 cases as of today, and about 1,000 deaths from COVID. So clearly challenged, but much better than some other countries in the world. And unfortunately, the outbreak in New South Wales has probably stabilised, but is still continuing about 1,000 cases a day, and Victoria is not far behind that, unfortunately. There has been a lot of reliance on mathematical modelling to inform our policies in Australia, and what this is shown for is from the roadmap to try and reopen Australia. And the idea is that as vaccination picks up in Australia, we will be able to start to relax some of these other restrictions and allow the economy and society to reopen again. So just moving on quickly to vaccines, we have relied heavily on two vaccines, the AstraZeneca vaccine and the Pfizer vaccine. We have other vaccines that are coming online now, the Moderna vaccine, as well as the Novavax vaccine, which will be coming at some stage in the future. So Australia's strategy was really to try and invest in different types of vaccines, some of the more newer vaccines, so AstraZeneca and Pfizer, and then some of the tried and true technologies, even though that might take a little longer, because obviously we didn't know at that time which one would work. There were some homegrown vaccines, the Tsioutis vaccine developed by the University of Queensland, which unfortunately failed to proceed. In June, it was realized that there was this issue with the AstraZeneca vaccine. So initially there had been a recommendation made by the immunization, so our NITAG, our National Immunization Technical Advisory Group, about a preference for Pfizer in people under 50, and then in June that was changed to under 60 because of the risk of TTS. And just noting, this time was that June was when there weren't many cases of COVID in Australia, and it was just before the outbreak in New South Wales. And so what has been a problem is trying to communicate the risks and balances the risks and benefits of vaccination to the community, trying to say that particularly for older people, the protection against infection and disease and dying from COVID is much stronger in older people compared to the very small risks. But in younger people, that becomes a little bit more difficult, and that is why there is the preferential recommendation for Pfizer in younger people. And obviously, as these outbreaks have proceeded, then that risk and balance also changes again. So this is where we're up to at the moment. We have vaccinated delivered about 25 million vaccinations. Our coverage is for the first dose is just over 70%. About almost half of the people are fully vaccinated. It is a little bit different across different jurisdictions in Australia, but we anticipate that we will get to the 70 or 80% target probably by the end of October and November, and hopefully things will start to stabilise in terms of the COVID cases. So just to conclude, we did manage to achieve local elimination of COVID early and in 2020, and then fought off a second wave in Victoria by late 2020. But this Delta variant is much more difficult to control, and has resulted in quite a long lockdown in the second half of this year. We have the vaccines being rolled out, but it has been relatively slow compared to many other countries. And it is looking like the road out of COVID for us will be a little bit bumpy, particularly with the active outbreaks in several states. So I might leave it there, and happy to take questions at the end, Evaristo.
Thank you, Dr. Cheng. And now we will look at the other side, our side, what's been happening. Cleo?
Yes, up next is Dr. Constantinos Tsioutis. Dr. Tsioutis is an internal medicine specialist with training in infection control and antimicrobial stewardship. He's a member of the Education Working Group of the European Committee on Infection Control. He's also assistant professor of internal medicine at the School of Medicine of the European University here in Cyprus. And also he's an advisor of local and international organizations in infection control issues. He's also the head of the Cyprus National Scientific Advisory Committee for COVID-19. Dr. Tsioutis will talk about the Delta wave in Cyprus and its differences compared to the Alpha wave back in the spring, as well as the current status of the Cypriot National Immunization Program. Dr. Tsioutis, the floor is yours.
Good morning. Constantinos, please turn on your mic. Down at the bottom, that's it.
Good morning.
Good morning, how are you?
I'm very good. I'm very well. I hope you are well as well. And I'd like
Can I just say something that that I really liked? Dr. Tsioutis is an Australian kindergarten alumnus
Yeah,
from Sydney.
that was like one pandemic ago. So, well, for my part, I'd like to thank you very much for this invitation. And I think the events like this, where we present the characteristics of our countries and make comparisons, is something that's really necessary. It was necessary from the beginning of this pandemic. International exchange of ideas, information is something that was probably lacking, and perhaps is still lacking. And it's another lesson that we have learned with this pandemic. So I'll go briefly. Good. Okay. So I hope I'm gonna, Sakis, just gonna change my slides, right? And it's gonna
Please.
be.
Yes. You control from here.
So it's working.
Yes.
So I'm gonna focus on the Delta wave in Cyprus, the current situation in Cyprus, with a few comparisons with previous waves or surges in our country, and also a few words about the current status of our immunization program for COVID-19. Cyprus has certain characteristics. It's a small island country in the Mediterranean. It has a population of around 900,000, according to the 2011 census. We have very specific points of entry, very specific airports and other points of entry, which make it easier, let's say, for us to control and check. We have established an active and very effective contact tracing unit since the beginning of the pandemic, which has helped us a lot in gathering data, real-time data, and helping us implement measures and interventions. We have a very limited use of public transport. That's very important when we want to see transmission potential. And also very few and small super spreading venues, which were actually closed from the beginning when we detected our first cases on March 9th, 2020. So these, I believe, are issues that contributed to seeing very few actually super spreading events and big epidemics up to now. Our national culture, as you well know, is to protect our vulnerable and to volunteer. We have a very good, a very strong family relationship, and that is, let's say, a type of motivation to protect them that has helped us throughout these months. And thanks to the newly established general health system that was started in 2019, almost everyone has a personal relationship with their doctor. They can directly communicate with them, and this, has, I believe, has also, and from personal experience, has also helped into strengthening our primary healthcare approach to COVID patients. Our elderly citizens, those above 60 years of age, represent about 1/4 of our population. And on the other side, we have limited genomic surveillance capacity until now. And many of our surveillance was based on analysis performed by the ECDC. In brief, up to now, we have confirmed 117,000 cases. Mortality is quite low. The case fatality ratio in Cyprus is about 0.5%, and we have a rather low mortality rate compared to other European countries. Nearly 5% of our patients have needed hospital care until now, and this is a rate, a proportion that has changed after our alpha wave in last winter. It was higher, but as the alpha variant entered our community and transmission increased, especially among the younger ages, this rate gradually decreased, and it's steady around 4.5, 4.7%. As you can see in the graph, we have differences, important differences between our different districts as regards to the total number, the prevalence of our cases, and this also has led to different application of different measures or different surveillance measures in the different districts of our country. From the beginning of the pandemic, we've had, let's say, 4 distinct waves, and as you can see, the first one was rather, in retrospect, was rather small and led to our first lockdown at the end of March 2020. That allowed us to, let's say, regroup and reorganize. And as you can see, we had a very good de-escalation phase during last summer until autumn, when we had this important surge. We entered a 2 to 3 week lockdown in January 2021. Some improvement thanks to that lockdown and other measures. Also, this period is characterized by a local lockdown that we had in 2 districts in Cyprus, because those districts, especially during October and November 2020, accounted for nearly 3/4 of our cases. However, distribution and spread throughout the country couldn't be stopped and led to a countrywide lockdown. And then we had the Alpha variant wave that led to another lockdown in April 2020. It was a 2-week lockdown. It was something like a circuit breaker, and you can see how low were the cases after this lockdown. Now, in summer, we've had the most severe wave, severe not only in number of cases, but also as regards to hospitalizations and deaths. It's a Delta wave, and through analysis, we know that nearly 100% of our cases were due to the Delta variant. These waves are also reflected in our ICU admissions. After the first wave, we established a new 25-bed ICU in Nicosia, which eventually was very much needed. Around 10% of hospitalizations end up in the ICU. The big problem was, again, this summer with the Delta wave, when ICU capacity exceeded, let's say, the critical rate of 80%. And also this wave led to the most deadly month of our pandemic, which was August 2021. So initially, how did we respond as a country? We established early collaboration between the scientific community, universities, with the establishment of the Scientific Advisory Committee, with the Ministry of Health that has also the public health services, with which we've been working since then, and also other authorities that from other ministries and from other public sectors. We applied strict entry criteria for inbound travelers even from February 2020, and these criteria are still remain pretty much strict, with categorization of incomers from different countries in 4 categories. This has been going on since last year, and has appeared through analysis as very effective also in predicting that a country, based on the positivity of incomers, of the cases that we had from each country. It was very predictive of the situation in each respective country. Our contact tracing has remained very active, and I'll elaborate a bit more on that later. We scaled up our testing capacity. We began with just a few hundred of PCR tests at the beginning. Then we established a minimum of 1,000 PCR tests per day. After we brought the rapid antigen tests, this capacity skyrocketed, and now today we perform around 50,000 tests per day. Within this capacity, we also do targeted testing in areas, in high-risk groups, and depending on what our observations are. And we have established a specific COVID hospital, as you know, and a new ICU, as I said. So the basis of our control from the beginning of our control and surveillance is TTI, testing, tracing, and isolating. And this has been the hallmark, I would say, that have characterized our interventions from the beginning of the pandemic. You see the very high rate of tests that we perform in Cyprus. We've performed more than 12 million tests. It's like as if we've tested our population 12 times over. And compared to other European countries, we have some of even the highest testing rate per population in Cyprus. And this is the current situation as regards to test positivity. We have a low positivity ratio. Nowadays it's around 0.3. I'll comment on that a bit later, because it's also owed to some different practices that we applied as a country. Now I'll just analyze a bit more about testing, because there are some interesting things to see. As you know, in Cyprus, we've established the use of Safe Pass to enter any closed or public space. The Safe Pass means that someone has to have been a COVID case the past 6 months, or needs to have been vaccinated for COVID with at least 1 dose, or should carry a negative test, PCR or rapid test for COVID the past 72 hours to be allowed a Safe Pass and enter any of these places. And you see here, and at the beginning of May, that as soon as the Safe Pass started to be used, the rapid increase in the number of tests on a daily. Now this started normalizing, let's say, because more people were being vaccinated at that period, especially in May and June. A huge number of our citizens were vaccinated, and therefore the need for testing decreased. This is a big holiday in Cyprus, the Holy Spirit holiday, on the 21st of June this year. And you see how low was the number of tests during that period and how much it increased right after. So this shows us it reflects maybe some behavioral issues and some cultural issues that we need to take into account when we think about measures in our countries. And on the 1st of August, it was the first day that non-vaccinated persons were not allowed a free antigen tests, so they had to pay for that. And again, you see that it started decreasing again. The number of tests has started decreasing. This could reflect the fact that people vaccinated, and therefore the need for testing decreased, or that because they had to pay for it, they decreased the number of tests that they performed. And this shows the positivity rate on a weekly basis from the beginning again of the pandemic in our country. You see that the positivity rate reflects the waves that we've had. This record positivity rate of 12% reflects the first part of the alpha wave in December that led to the lockdown of January, then decreased again. The other important that I figure is important is that in December we banned in-house gatherings during the Christmas period, and as soon as we did that, we saw a positivity rate decreasing. Maybe that was even more effective on decreasing transmission than the lockdown that followed. And again here, after applying the Safe Pass, and this is something weird because we consider that the majority of these people here that do the tests are non-vaccinated persons, and you see how much it decreased right after applying the Safe Pass. So this is something that we need to think about. And again, after this 3-day holiday, you see that the positivity rate increased up to 4% overall in our country. That's high. So it seems that the social gatherings during this holiday led to an increase, and it was a bad timing for this holiday because it coincided with more areas opening, and particularly the clubs and the bars that opened during the same period. So this whole positivity, high positivity, is reflected in the huge Delta wave that we had in summer. Now our vaccination coverage. Cyprus has a overall vaccination coverage in our population of around 2/3, 66% of our total population is vaccinated. It's not as high as we would like it to be, given that we have the Delta variant here. It's around 80% of our adults, but it's 66% of our total population. You see, it's close to the European Union average, but it's lower to other countries and lower to other European countries as well. These are per age, the vaccination rates per age. What I'd like to note here, in Cyprus, the majority now of vaccines are with the Comirnaty, the Pfizer vaccine. More than 2/3 of vaccinations are with this vaccine, and about a fourth is with the AstraZeneca vaccine, which after these safety issues that occurred, it was recommended that persons younger than the age of 50 avoid AstraZeneca. The other characteristic of Cyprus is that everyone has a choice. They can choose which vaccine to get. So even before this recommendation for use of the Vaxzevria, the AstraZeneca vaccine, we saw that the popularity, let's say, of the vaccine decreased. I'd like to note here that the huge majority of persons over the age of 60 are vaccinated. In my mind, it should be further strengthened and include also the over 50, because we saw in summer that age over 50 was the strongest risk factor for hospitalization and death. So in my mind, these rates are something that we need to address, and we're actually now performing a countrywide study to record the behaviors and the attitudes of these ages towards the pandemic and the vaccine. And the other issue is that the coverage of the younger ages is gradually increasing on a slow pace, but it is increasing. As you can see also, vaccination rates of children, 40% in the adolescents, and 25% in persons 12 to 15 years of age. Now, the current situation and the challenges that we have ahead. So on one hand, our situation is that we still have ongoing community transmission. We have around 100 cases per day, although these reflect a very low positivity rate. Let's not forget that testing now applies mainly to non-vaccinated persons. So we have 40 to 50,000 tests per day, which either are towards surveillance. For example, among them, we do around 10 to 12,000 tests per day in schools. But we know that vaccinated persons do not, and they're not obliged to do a test unless they've been a close contact or they have symptoms. The August, unfortunately, was the most deadly month here. We have been observing an increasing ratio of vaccinated persons among cases and among hospitalized. Nowadays, around 25% of hospitalized persons are fully vaccinated. And this is a trend that's been increasing. And that's why also we have started the booster dose in certain ages. I'll show you in the next slide, as of the beginning of this month. However, the number of hospitalizations is now decreasing. So we're gradually exiting this wave, or at least going towards a steady state. The challenge is that this positivity rate, as I said, does not reflect our actual situation. We have started recording outbreaks, especially in LTCFs, among both vaccinated and unvaccinated, because these are areas and spaces of high transmission because of their circumstances. We observe a low response to contact tracing. And why is that? Because the huge majority of our cases are young people. Okay, they're young adults, younger than the age of 25, 30 years old, and they are not very compliant, let's say, to what we ask of them for information on their recent contacts or their whereabouts so that we can do active contact tracing. This has been a problem since the beginning of this wave. The other problem that I see is that now in September, we have more further relaxations. Schools have opened, universities have opened, and many of them are applying face-to-face teaching, and there is no work from home requirement anymore. So these are, for me, are issues that might lead to a new resurgence within the next weeks. So our actions, first of all, is to start the boosting with a vaccination as of September 3rd for persons above the age of 65, immune compromised, and healthcare workers. So far, we've vaccinated more than 3,000 persons, and this rate will be increasing the next days. To others, vaccine hesitancy, especially among the high-risk groups, the high-risk ages, with local surveys. And we're going to continue the use of safe pass in all areas and spaces we have now, at least until the beginning of October. We've established repeated tests, and this is for me very, very important. There's been also a Lancet study last week that showed that even daily testing of close contacts could replace self-isolation because it allows for early detection and isolation. So we're starting repeated tests in all students in schools and also in LTCFs. This has been going on since December 2020 and has worked really well. LTCFs have a very, very, very low positivity rate since then, since we began this program, a positivity rate below the average positivity rate in our population. We have now again established dedicated contact tracers to others high-risk groups and areas, specific groups of contact tracers, and now we're starting to address the big issue of post-COVID, because with 100,000 cases the last year, and 60% of them having had symptoms, and about 20 to 30% of them having long COVID, you realize that we have around at least 20,000 people who've had or are still having long COVID issues, and these persons need to be specifically addressed. So that's from my part, and thank you very much.
Thank you very much, Constantinos, and we really appreciate your presence and your time and accepting our invitation.
Thanks. Thanks.
Okay. To bring on a person who has been with us and supporting us and advising us and contributing to this whole project, and he's no other than Dr. Nicholas Tsioutis. Thank you very much, Nicola, for everything. And a few words about you and your talk. Dr. Tsioutis will provide an overview of the international vaccine hesitancy setting for COVID-19 vaccines, as documented by a number of recent studies. He will unpack the driving factors behind the development during the course of vaccination and discuss the impact that has on the course of the pandemic. At the end of the talk, Dr. Tsioutis will summarize the key proposed actions and strategies that can address the main drivers of vaccine hesitancy. And of course, a few words about Nicholas Tsioutis, who also has a very strong contact and relationship with Australia. He's an assistant professor of pharmacology, the head of experimental pharmacology laboratory, and the head of the zebrafish laboratory at the University of Cyprus Medical School. Previously, he worked for 3 years as lecturer in pharmacological sciences at the University of Tasmania School of Pharmacy. He's an active member of professional societies such as the British Pharmacological Society, BPS, the American Society for Pharmacology and Therapeutics, and the Association for Medical Education in Europe. Dr. Tsioutis, thank you very much once again, and please, the microphone and the camera is yours.
Thank you very much. I'm just going to share my screen. Okay, I'm not sure if you can see.
Yes.
The slide's perfect. So I'm just going to talk about vaccine hesitancy, but obviously this subject is very deep and it has a lot of extensions, social, psychological, even political extensions. And obviously I'm not going to be able to cover the whole status and the whole platform on vaccine hesitancy. But what I'm going to do is I'm going to describe just the key points about vaccine hesitancy. I'm going to describe where we are now in both countries, Australia and Cyprus, and really provide some food for thought in terms of strategies to reduce or even eliminate vaccine hesitancy. So a little bit about vaccine hesitancy as a concept and a definition. It's the delay of acceptance or refusal of vaccines despite the availability of vaccination services. And this is a definition adopted by WHO and the ECDC and other bodies. Now, the important thing about vaccine hesitancy in order to reach action is to actually follow these 3 steps, actually measure vaccine hesitancy, because we do know that it can be very variable between countries and even within countries. So measurement of this vaccine hesitancy, and obviously we do know that vaccine hesitancy also has variability depending on which vaccines we're talking about. So measurement of this vaccine hesitancy and then identifying the reasons behind this hesitancy with studies. And then obviously these 2 measures will provide some idea of what the action should be to address those issues. And of course, many countries have tried to follow that model. And obviously that model is based on data. So looking at just a very selected data from the literature, there is only a few papers in the literature that have described vaccine hesitancy globally. One paper is this one, looking at 19 different countries, talking to more than 13,000 people. And the key issues that came out from this study was the fact that it was about 28%, roughly 30% across the board, people of not willing to accept a COVID-19 vaccine, or they are neutral in general, depending on the topic of subject. So there is also a matter of willingness to accept a COVID vaccine if it will be mandated. And here we see a very, very big jump to a 50%. So we do see here what's the response of people to mandates. And that's a very, very important issue when we're talking about strategies to mitigate vaccine hesitancy. Looking at most of the studies, one can recognize 4 different issues. First of all, vaccine hesitancy is a very serious problem, right? So it is a direct threat to public health. It will promote hospitalizations and even deaths in some cases, because people who are becoming vaccine hesitancy might also be people who are very vulnerable. The second common issue that most papers in the literature have addressed is the distinguishment between misinformation and disinformation. These are 2 different things. Misinformation, obviously, it's a misunderstanding, some issues in the communication in terms of information, scientific information about vaccines. But disinformation is the active, knowing reason for disseminating wrong information to people. And these are obviously 2 different things. And there's quite a few studies now trying to address disinformation, because obviously we can understand that when we're talking about misinformation, some things can be corrected or changed if communication improves, but disinformation is something entirely different. And obviously you can see that in the last few months, some social platforms have inhibited people from spreading wrong information given the fact that they knew it was a wrong information. So based on evidence of disinformation. A third issue is the fact that most of the vaccine hesitancy seems to be originated from concerns about the safety, but not only the safety, but also the efficacy of vaccines, and also their usefulness to COVID-19. So these three are important issues to discuss when we're talking about science communication. And the last but very important issue is the distrust and also the politicization of issues around COVID-19 vaccines. And this distrust is obviously has very deep roots into societies, into political systems, and it spurs from other events that have happened historically in this country. So these four issues around vaccine hesitancy have to be addressed independently. Now, before we talk about vaccine hesitancy in Cyprus, it's important to just see the vaccination status. Kostas have mentioned a few numbers. 66% of people in Cyprus are vaccinated, and this is very, very close, if not exactly the same as the European Union. So the vaccination has a trend of increasing per time, and obviously you can see that it has picked up around May, increasing its rate, but it's still growing, although a few models show the fact that it will flatten out in a few months. And looking at daily doses, you can see that the daily doses are continuously decreasing, which is normal if you think about increasing percentages of vaccinations, but it also provides an idea of how much vaccine hesitancy remains in the unvaccinated groups at the moment. And looking at vaccine hesitancy specifically in Cyprus, there's only a few studies, unfortunately, but these few studies are providing some good information. This is a very, very early study back in December 2020, so that was before vaccines being introduced in Cyprus and in Europe, looking at attitudes and acceptance among nurses and midwives. And obviously health care workers are a very important part of science communication as well. And that was the first signal of vaccine hesitancy in terms of studies in Cyprus, a very, very worrying percentage. 70% of nurses and midwives were describing themselves as vaccine hesitant. And that, again, that's before vaccines being introduced. That number has dropped significantly after vaccine introduction, but it's still very, very high among nurses and midwives. And some of the predictors of acceptance in terms of COVID-19 vaccines has been three things. First of all, it's the seasonal flu vaccination, the annual seasonal flu vaccination. So nurses that do perform this vaccination, accept this vaccination annually, have higher acceptance rates for COVID vaccines as well. Allowing the recommended vaccinations for healthcare professionals and also working in the private sector. These are the three predictors for that the study has identified for acceptance of COVID-19 vaccines. There is also another important study that again happened before vaccines being introduced in Cyprus, but it actually tried to compare Greece and Cyprus. And that's a very important paper because it actually it can provide you with information based on culture. You know, we know that the Greek culture and the Cypriot culture is very, very similar, if not identical, and differences in these in vaccine hesitancy between Cyprus and Greece in the healthcare personnel could provide you with deep information. What we see here is we see the intention to get vaccinated from healthcare personnel is very, very different in Greece and Cyprus, was different back in December 2020. So the intention to get vaccinated, it was only 35% in Cyprus, and that created a very big issue. And we also identified that through science communication with the public, the fact that doctors, not so much doctors, because in this percentage, it was more driven by nurses not being willing to vaccinate it, but it really resonated and reflected on the vaccine hesitancy of people. And as Kostas, I think, mentioned, it's very normal, and actually most people who before getting vaccinated, they ask their doctor, they have a personal relationship with their doctor, and if their doctor doesn't approve of a vaccination for themselves as well as for their patients, it's very difficult to overcome that. And of course, the primary reasons for not being vaccinated have been identified as the safety, of course, but the secondary reasons are very also interesting, because you can see that the vaccine efficacy, which is, you don't really see it in a lot of surveys, being a reason for not getting vaccinated, was quite high among healthcare personnel in Cyprus. 64% think that the vaccine won't work in terms of stopping this pandemic, and that's an issue, obviously, of scientific communication in terms of how vaccines work and what's the data that support vaccine efficacy for COVID-19 vaccines. There is also a very interesting study, very large study in terms not on participation, but in terms of widening participation. It's a study looking at the trust in authorities and looking at demographic factors in the general population. And that study was performed between March 20 and March 21. So it's really a year getting data. And that study provided some good insights. First of all, it has identified a number, roughly about 23% of people being unsure if the vaccines will end the pandemic. And that actually incorporated the fact, the numbers that we looked earlier about vaccine efficacy. So 23% of people not only don't trust vaccines, but they don't think there will be a tool to end this pandemic. That's a very important percentage. 16% completely disagree with the fact that vaccines are useful in general, but also for COVID-19. So that's a very, very important percent. But we also see hesitancy among young people, especially people in their 20s. They are significantly more hesitant than other ages. And that's obviously an issue that has been identified through science communication by a number of universities here in Cyprus. The fact that we have initiated the communication about vaccine efficacy and safety to our population based on vulnerability. That was the first issue. So we said, look, young people, you'll find in terms of COVID-19, but older people are vulnerable. We need to protect them. And that has been absorbed into young people's consciousness, it seems. And it's very difficult now to convince them to get vaccinated, since they don't think they have an issue with COVID-19. And of course, some of the factors that can predict vaccine hesitancy, and we can see that internationally as well, is lower education level, also income is another predictor. Now, looking similarly, vaccinations in Australia. Of course, Australia had a slower rollout in the beginning of vaccines availability. Around 60% of people are vaccinated, but there is a smaller percentage in terms of a second dose. And it's important to look at second doses when you're looking at vaccination coverage, because we know that for the Delta variant, the second dose is very, very important in terms of protection. But we see a continuously increasing trend in vaccinations in people fully vaccinated. The curve hasn't flattened yet, which is a very, very good sign, which means that there's quite a way to go to cover the rest of the population. And obviously that also is being reflected to daily doses. So daily doses also go up in Australia. So there is a very, very good chance that we will reach in Australia the targets of 80%. But looking at hesitancy in Australia, fortunately, there's more data than Cyprus. And this is data from our World in Data, which is they get data from the Imperial College London. And what we see here, we see that the people who are hesitant to vaccines, and that's the red bit in this graph, has been quite high at the beginning of 2021, that's February, but it did decrease. And if you look at the graph, what you see here is the blue is the people who get vaccinated. Obviously, it gets higher because people are getting vaccinated. But what you want to see is you want to see the shrinkage of the red bit and the yellow bit. So that has been reduced, which means that the more people get vaccinated, the less percentage of people being hesitant there is. And that's actually a trend that you can see in other countries as well. And this is, I know the letters are very small for you to read, but we're actually interested to see the trend in this red bit. And you can see there's quite a difference between countries, right? So you see France is following Australia in this trend. The red bit, the people who are absolutely very strict in being hesitant, has been shrinking as we go, but we don't see the same thing in England. In the UK, it's a little bit steady, and that's a matter of concern as well. And you see various other versions in other countries. Of course, South Korea has very smaller ratio of people getting vaccinated, but you do see in South Korea the fact that you had people who were a bit uncertain. Actually, more people were uncertain than people who are completely hesitant to be vaccinated. That actually shrank quite a lot when vaccinations increased. So looking at vaccine hesitancy at the moment in Australia and comparing it with other countries, you see that Australia has a smaller percentage than most of the other countries, but it does have a low percent of people that have been vaccinated. Of course, that's the reasons that we discussed previously. And what we want to see is as this blue bit increases, we want to see this 17% being decreased further. Now, vaccine hesitancy in Australia has fallen mostly among 18 to 44-year-olds and above 65, but it has remained stable in the middle-aged group, and that's a very informed. It's a topic that can inform your strategies on how to mitigate this hesitancy. We don't see any gender differences, although we do have data that in Australia that show that women used to be more hesitant in the past for other vaccines. And we also do see differences between states, and Victoria does have the largest fall in hesitancy since vaccinations have been initiated. And this is a comparison graph that shows different states in Australia and looking at vaccine hesitancy. So you see different numbers, and you see the change in the vaccine hesitancy within states as well. That has shifted the balance for some states. There is enough evidence in literature as well talking about vaccine hesitancy, but I want to focus a little bit more in the trust in the government in terms of intention to vaccinate. And this is a study that has compared the United States, the UK, and Australia. And what we do see for Australia is we see that vaccine-specific concerns is about 16%, and the same percent goes for the distrust of people to government decision-making. But when you go and look at willingness to be vaccinated between cities, you see roughly the same percentage. So what this shows you, it shows you that the people who have concerns in terms of safety of vaccines are actually the same number of people who are also equally have distrust in either the strategies of government and policy making. So in a nutshell, to summarize, we do see differences in vaccine hesitancy behavior in Cyprus and Australia. In Cyprus, we do have predominantly young people being more hesitant, but we do have also some middle-aged hesitancy, as Kostas has described as well. That's a very, very important issue, and especially for Australia, because we do know that for the Delta variant, age is a very, very critical factor in terms of ICUs, hospitalizations. It's very difficult to put a number in vaccine hesitancy in Cyprus at the moment, because all we have is snapshots of different studies, but we have more data for Australia that show this percentage. And actually, that's a very, very high percentage. It can deviate, it can be variable as we go, as I've shown before with data, but it makes you actually think and provide some food for thought in terms of how we can address this Delta variant. We won't be able to control the pandemic with a Delta variant if we have 30% of people being hesitant. So we have to really address that, and we have to act urgently. And of course, we're unsure about changes in Cyprus because we don't have data, but we do see some gradual reduction over time in Australia, which is actually a very good thing. Distrust is a major factor for both countries. So I think that can provide some information to policies for the future. And I'm going to finish with my last slide, looking at just the main strategies that all these studies have in common in terms of proposing. So we need to have a direct communication to people with their concerns and misconceptions. We need to address historic issues about distrust. There are specific communities in our countries that have particularly higher distrust in general in the government policies, and we have to address that. And I've heard Professor McIntyre, who in CNN yesterday, who wrote a book about how to talk to hesitant people, and he said that one way to build trust is to allow people that are within those communities to communicate things about vaccines to these people. So that's some food for thought in terms of strategy. Being sensitive about religious and philosophical beliefs, and that's particularly important for Cyprus, because we do know that there are many people who are very strict in their religious beliefs in terms of COVID-19 vaccines. That's an issue, and we've seen that this percentage hasn't really decreased, although the head of the church has communicated the fact to the believers that COVID-19 vaccines are safe, effective. We need to follow the health rules and proposals. We need to engage formal and informal opinion leaders. That's also a part of the trusting issue. We need to engage local trusted leaders with community discussions. Of course, communication is a big part in reducing vaccine hesitancy. Clear communication, consistent communication by the government and by the policymakers towards vaccines. And of course, evidence-based communication. This has proven to be effective for misinformation, but obviously it's an issue for disinformation. That's all for me. Thank you very much.
Thank you very much, Nicholas. And the last speaker will be the gentleman from Yeroskipu, Paphos. And Cleo, please introduce us Dr. Herodotou.
Yes. Last but definitely not least, Dr. Herodotou was born here in Paphos, in Cyprus, and graduated from the National and Kapodistrian University of Athens Medical School in 1974. He specialized in surgery at the General Hospital of Athens, and in 1978, he moved to Melbourne, where he specialized in general medicine. For the last 40 years, he holds the position of consultant in the emergency medicine and punch at the Northern Hospital. He's clinical supervisor and senior lecturer in the Faculty of Medicine and Dentistry and Health Sciences at the University of Melbourne. He's also a fellow of the Academic of Clinical Teachers of the Faculty of Medicine at the University of Melbourne. He was awarded the title of Best Teacher for the year of the academic year 2018-2019. Dr. Herodotou will talk about how the COVID-19 pandemic has been a challenge to all the health services A big challenge has also been the testing of the systems, the identification of gaps, and the preparation and training of the staff. He will also describe how they use the simulation for their preparation in real-life circumstances. Dr. Herodotou, welcome, and the floor is yours.
Thank you very much, everyone, and nice to be with you tonight. And I want to say to Sakis and Cleo, thank you for the invite. It's my honor to be with you today. I wanted to say that I'm not really a researcher, so my talk is mainly based on my experiences in the hospital and the community where I work. I would just to share the screen first. Oh, okay. Am I sharing the screen now? Can you see me?
Not yet.
Not yet.
Not yet.
Sorry.
You will need to. Yes.
Yeah, just 1 second. I think I will share it now. Yep.
Not on yet.
Not yet. Sorry, I will share the entire screen there because that's what we did before. No. Sorry.
No problem at all.
What about now? No, you can't see me still. I'll try one more. Share the screen. Share the screen. Share the screen. Okay. You can't see me still?
Not at all.
Windows screen. Share. Okay, now you should be.
Coming on now? Yes, yes, yes.
Good,
Okay,
thank you.
that's fine.
Okay, a few things about my hospital. The hospital I work is the Northern Hospital. It's a major community hospital. It lies in the north of Melbourne. It is a 400-bed hospital serving the northern suburbs of Melbourne. Despite that, relatively, it's not a very large hospital. It has the busiest emergency department in the state of Victoria and one of the busiest in Australia. I think it's the second busiest in Australia. About 120, sorry, can you hear me?
Yes, yes, all fine.
Okay, thank you. About 120 to 130,000 patients go through our emergency department annually. This is the emergency department. That's the outside of the emergency department. These ambulances, they come there. We used to have 4 or 5 ambulances outside of the, if we saw 4 or 5 or 6 ambulances really ramping outside of the emergency department, we used to say it's very busy. Now we see 10, 12. The other day I saw 15 ambulances around up the emergency department, ready to give us patients, to unload patients inside the emergency department. So for people who think that the COVID-19 is just another flu, it's really so wrong. I've never seen 15 ambulances during the winter time before trying to give us patients. This is the inside of the emergency department. This is all the resuscitation rooms. This is the back doors of the emergency department. Anybody who comes through has to stop there and put the PPEs on. This is the main assessment area inside the emergency department. And the purpose of my presentation is to show as briefly as possible the roadmap we took in the emergency department to prepare ourselves and the hospital for the pandemic. We had to prepare for the worst, hoping that the worst wouldn't eventuate. We had to prepare so we could avoid the possibility of the hospital being overwhelmed by the sheer number of patients or by the acuity of the cases. Also, main aim of that roadmap was to protect as much as possible the first line staff. Of course, the details of what we did may not be really that very important to you or to the staff or the management or other hospitals, because every hospital has its own way of functioning, and that depends on its size, on its resources, on its health system, but also, very importantly, on its location. And by location, I mean the socioeconomic status of the people in the catchment area of that hospital. As Alan said, from our experience in Australia, in Sydney and Victoria, Melbourne, the main number of the patients are from the poorer socioeconomic groups in the western suburbs of Sydney and the northwest suburbs of Melbourne. In our planning, we found that we couldn't really copy other overseas hospitals, but neither we could copy even other Australian hospitals because, as I said before, every hospital is unique. This will be the first part of my talk. The second part is I will try to see if there are any similarities of the problems we face with the problems the various public health authorities and the government faces in the management of the pandemic. See if there are any lessons for them to learn from our experiences. Lessons we learn. As I said, they really are not very important. The slides is just our experiences, what we did to prepare the hospital. Lessons though we learn, you need to study a lot and learn from the accumulated experience of others, the ones who came face to face with the pandemic before us. In our case, was China, was Europe, was North and South America. You must use their experiences, but importantly, you need to adapt these experiences and their experiences to your reality. We found that one thing is to design and plan the changes, but the other, the more difficult, is to bring the staff with you. Hospital like ours with thousands and thousands of staff, you can imagine how difficult it's really to bring them with you when you're taking measures of major changes. People are difficult to accept radical changes when they work for a long time in the same environment and they repeat again and again the same thing, and it seems to them that the system is working. To challenge them with radical change after change is extremely hard. Creates the feeling of insecurity and people lose the trust. You give them the feeling that you are making decisions on their own, and that makes people feeling disillusioned and threatened. That's why a lot of nursing staff resign, or instead full-time, they go into part-time, just because exactly of these reasons, of these problems. In that process, we should not forget that these people have also their own personal and family problems, anxieties and other challenges, i.e. possibly loss of income by one or both partners. One of the partners must stay home with the children who must stay off the school. The responsibility for home distance learning for the children is a huge responsibility. The fear of the disease, the responsibility towards the older members of the family, the split of the families, and the list goes on and on. All this, together with so many other issues, make everything so hard. So how do we overcome these issues? I think some of the previous speakers touched that, but from our experience, we must manage to bring all the stuff with us. We must make people feel part of the solution. In other words, by making people to feel that they are part of the thinking, part of the design, and part of the change, and part of the implementation of the change, that helps. Organize brainstorm committees and brainstorm meetings. Let people express their doubts. Be positive for the change and not negative for the mistakes. Take the attitude of we don't change this one or the other one because they are wrong, but because they are good and we are trying to make them better. Give credit to the new ideas and to the people who are the bearers of those ideas. And now, how did we find ourselves in this predicament? And what I mean by this is how could we explain the phenomenon that people in the middle of the pandemic, in the middle of the enormous challenges for the whole humanity, they doubt even the existence of it. They call it little flu. I wish they could come to see the little flu in the emergency department and the intensive care units of the hospitals, where literally people suffocate rapidly. How could it be that those otherwise seemingly normal and educated people believing in all these crazy conspiracy theories? They dispute the honesty of the science. They lose trust for the institutions. They dispute the honesty of the governments. They dispute the reality which they can see with their own eyes. Do all this remind you of any psychiatric illness? And that is not a phenomenon unique for Greece or Cyprus. The phenomenon in a larger or in a less degree is observed everywhere. And this phenomenon wouldn't be that important if it wasn't affecting in so many ways the management of this disease. If it wasn't becoming a break in our attempts to manage this enormous problem that the humanity is facing today. And what about the outcry of some people that the mandates of the form of no vaccination, no entry in some venues, or no job, no work for some industries are discriminating and against the civil rights? We can debate that later if you want, time permitting, but obviously are not all discriminating at all. They are quite legitimate distinctions, and distinctions like this we make in life every day. The sociologists and the historians of the present and the future will have to study the phenomenon and give some rational explanations for that. From my part, I think that the main reason is the rapid rate of so many and very often so conflicting messages. From the beginning of the pandemic, the messages are very conflicting. Initially, messages came from out of China, were mixed, again, conflicting and very confusing, either purposely or because of lack of information and knowledge about the disease. And I would like to believe that the latter was the case. They were really very confusing. The initial messages coming out of the WHO were also conflicting and confusing. Initially was no pandemic, then became pandemic. Initially, no need for restriction of movements of the people. Later, the best single measure was the restriction. The masks, initially not that important, later on very important. The messages from the governments and the various public health authorities were and still are conflicting and confusing, especially to the non-science trained individuals. In those, we should also mention the media, which with their own assumption of need for equal cover, they give oxygen to the people who spread those crazy ideas, and the list goes on. In the list, I must also add the science. We are remembered that at the beginning, we said that it will take 3 to 5 years for the vaccines to be developed and ready to go in the people's arms. It took only 1 year. The AstraZeneca initially was good for all, then good for the above 60, and later only for the above 50. Now it's good again for everyone because we need it. In the mix of the problems, I should not forget to mention also Donald Trump. Do you remember him? I personally tried to forget him. He did everything in his power to confuse everybody. He confused the antiviral treatment with the detergents. He confused the malaria with the COVID-19, and he was suggesting as treatment the chloroquine. He called little flu, he called it Chinese flu. And his absolute solution for the pandemic, do you remember what it was? Stop testing, he said. If we stop testing, then nobody will be positive. What a brilliant idea from a brilliant brain. At least he had consistency. But why all these inconsistencies? The reason is because there is no consistency in the behavior of the COVID-19. If we have learned one thing from the pandemic, that is the unpredictability of the behavior of this virus. Because of this, the messages and the measures must often change and be adopted to the new realities and the new knowledge we get. But, and this I think is very important, the reasons for the changes must be clearly explained and justified to the people so they can understand and then accept changes. In Australia, I think we were the victims of our initial successes. Because with the strict measures and taking advantage of the fact that Australia is a big island, we managed to keep the disease at bay for a long time. Because of that, the government was slow to educate people. Because of that, the anti-vaxxers found it easy to spread all the misinformation and conspiracy theories and create confusion and mistrust. Because of the initial successes, the government was also too slow to secure contracts early for enough vaccines. Another problem, as it was proven later, was that the AstraZeneca vaccine, which is manufactured in Australia, became the main vaccine that the government relied heavily on. That became a big problem when it was decided that the AstraZeneca was recommended only for the above the 50s or the above the 60s. When the second wave of Delta variant appeared, which seems to be much more virulent and much more transmissible, first in Sydney and later in Victoria, again the government hands, so to speak, were tied because we didn't have enough and we didn't have variety of vaccines. To be fair to the government, when these initial mistakes were identified, it moved very quickly and effectively. It secured a variety of vaccines and it started an intense public education asking the people to get the vaccine. The great majority of the people of the Australian population, from my experience, are people who like to obey the laws and the rules. Because of that, and because of the fear generated from the rapid escalation of the numbers of the cases in Sydney and Melbourne, people decided to get the vaccination centres and get the jab. So in a relatively short period of time, we exceeded the initial target of 70% with the first injection, and soon we will reach the 80% vaccination rate. The Australian experience shows that good and well-targeted public campaigns can make a lot of difference. And now about ourselves and our responsibilities. Despite all these limitations, as people who believe and trust the science and people who are fighting in the first line, not only we have the right to be involved, but we have the moral obligation to do everything we can to educate and influence the people. We should try to have as much consistency in our messages as possible. We must be respectful and polite. We should respect the fact that some people are not philosophically against the vaccination, but they are naturally fearful or they are victims of social media misinformation. We should always use simple language and evidence-based facts and not emotions. Emotions in this case can only inflame and make the situation worse. At the end, we must spread the message of hope. The humanity is destined to win this battle. It has gone through much more serious battles than this. We must first believe it ourselves and then give this message of hope to the rest of the population. And thank you all very much and keep safe.
Thank you very much, Dr. Herodotou, and your messages of hope. Now, thank you to all the speakers, and we shall, as discussed, have a roundtable discussion. Perhaps the experts from Australia and from Cyprus here would like to discuss some of the facts and figures, some of the ideas and experiences expressed through the presentations. And of course, Cleo, I don't know if we have any questions from people, but we could look at them a little bit later on. So Dr. Tsioutis, Dr. Tsioutis, Dr. Cheng, Dr. Herodotou, thank you. And please, if there is something that perhaps you would like to discuss, please go ahead. Professor? Yes.
Yeah, I have a question for Dr. Tsioutis. That was a fantastic account of the strategy in Cyprus, and congratulations on that sort of well thought through strategy. I was just wondering, we are considering vaccine passports, I guess the version of Safe Pass that you have, and also we are starting to move towards antigen testing. We haven't really used it very much to date, and I was just wondering if you could just briefly outline your experience with the Safe Pass system, and also with antigen testing, whether you've had false positives and how you capture the results if people are doing it at home or where they do the testing?
Yeah, thank you for the question. I think it's a very important issue now. That I think that scaling up testing will actually allow for opening spaces and keeping them safe. So the big issue here is how, as you said correctly, how to control for these passports, testing passports, vaccine passports, whatever. That's one thing, and the other thing is how often and where to do it. We chose not to allow for self-testing, or anyway not to acknowledge self-testing as a proof of negative testing, because we increased the sites where people could go and perform the tests. Imagine that at some point we could even test up to 1/9 of our population on a single day, just on testing sites that the Ministry of Health had all around the country. However, one thing that we did not address, and we should have, is to make an electronic system where you could actually record everything. So perhaps using these tests through a barcode system would be much more useful to have real-time data to monitor changes, and also to safely control that someone who has a test with them is true. We had a problem with fake test results. Still have this problem because it's all paper-based. That's a big issue. So that's why I think that this is one thing that you should, before establishing anything, you should address. Now, our tests initially, we increased our capacity in January, in December actually. It was very useful for surveillance purposes. Now it doesn't really help surveillance. It actually helps to detect the positive ones, isolate them, and therefore allow for, let's say, COVID-free spaces. However, as vaccine coverage increases, then the possibility of a positive person being vaccinated also increases, as you very well know. And this is a point that we have reached now. When 80% of our adult population are vaccinated, there's a 50-50 chance that a positive case will be vaccinated. That would be a problem in closed spaces where this passport, this safe pass, allows someone who's vaccinated to enter with no testing at all. This is something that we need to address from now on, if we need to still control spread. So establish your goals if you want to use it for surveillance or just for opening your different spaces. Keep monitoring it through an electronic system. I wouldn't go for self-testing now, at least at the beginning. We have them, but they are used informally. So if someone needs proof of negative testing, has to go to specific sites, and have this in mind. And I think that Australia now has reached a percentage of vaccine coverage where you will start seeing this. It's not that morbidity will increase if vaccinated persons start transmitting and acquiring COVID, but it's that you will have a different type of surge that you will need, I guess, to control. Otherwise, we will all end up like Israel ended up, having a huge problem and being just one step from a lockdown, while they had 60% of their population, of the adult population, vaccinated. So for me, massive testing. My problem, my issue with massive testing was exactly as you said, those false positives, especially as prevalence decreases, and that's why at the beginning we sought to confirm all positive antigen tests with PCR. We found that there was a high correlation between positives. There was a high positive predictive value of antigen tests, but we did this at a time when we had higher than 4% positivity rate, a high prevalence of disease. Now that we have a lower prevalence of disease, I believe that our false positives, especially in asymptomatics, will increase, and we need to reintroduce confirmation with PCR. So this is another issue that you need to address and have in mind. PCR confirmation, especially of asymptomatic cases, and PCR confirmation, of course, of symptomatic antigen negative cases.
Yes, Dr. Herodotou.
No, it's okay. Don't worry. It's
okay.
the minute.
Another question, something else to discuss or address? If not, I think you should. Please, Nicholas.
Sorry, I was just wondering, just a quick question to Stefan, whether he has seen through his experience in the hospital the effect of vaccine hesitancy in people, in your communication with people who obviously visit the hospital, being hospitalized. So if you've seen this, has it been has it changed through since the beginning of vaccinations? Or
it has. It definitely has. The fact that now we've got it in so high rate, so high numbers in Victoria and in Sydney, people hear about that, hear about the deaths we've got. The hesitancy has changed dramatically, I would say, the last few weeks. A lot of people come and ask for it. An example is that the northern suburbs, where we had the lowest rate of immunization, in 1 week, I think they went from 6, I don't remember exactly, but it was really dramatic escalation of the people who went and had the vaccination. And that was in the northern suburbs, where is really the lowest socioeconomic groups, lower education, with specific problems, communities, the acceptance now is much higher.
Yeah, I think if I recall correctly, it's gone up about 10% in a week, I think, in the northern suburbs.
Exactly, that's right. It was raised by 10%.
Very good.
I think there's always that issue that there's vaccines, vaccinators, and people wanting to be vaccinated, and you need to line all those three things up to get the vaccination program going. So we've had this issue that we haven't had enough vaccines. There's always the issue that when there's vaccine outlets, that they need to be convenient, and I think particularly the northern suburbs is an area that doesn't have a lot of general practitioners, so there has to be other sort of points of presence so that people can be vaccinated, and then addressing hesitancy, as has been pointed out, is important, but it's a magic system that has to line all those three things up, and one of them will always be a problem.
Yeah.
Just something that with what's happening in Melbourne at the moment, what we see, there's a lot of reaction to this long lockdown to the end of October. And it seems as if there is some sort of a demand to trade lives with freedoms, more or less, if I can put it that way, bluntly. People are hesitant and reacting. Is there any discussion about that? Any reason why this is happening so strongly, and especially, with the lockdown?
Yeah, look, I could probably answer that one if you like. So I think that. So I think last year we were probably just at the end of, we call it social license, when the population is starting to get sort of tetchy, and to say that, we've had enough. And we were right at the end of that when we managed to exit the restrictions. If we had gone on even another couple of weeks, I think it would have been much more difficult to keep the population with us. this year, I think the difficulty has been that we're not really seeing the results. So I think last year everyone could see, the numbers are coming down, and the debate that we're having is, well, why are we locked down when there's only 10 cases or 20 cases in the community? This year the numbers are still increasing, and we're still in lockdown. And I think everyone's a bit depressed, basically. And I think with that, we can see the community's anxiety play out, and people react to that in different ways. And my suspicion is that it's not a huge group that are these people that are protesting in the streets, and there is the worry that some of these groups have been hijacked by some crazy people, but it is still of some concern, and I do get the feeling that this year is a very different environment to last year. That we've done all of this, it just seems to have not gone quite so well. But I'm still hopeful, because eventually, once enough people get vaccinated, and I think we're starting to see that in New South Wales now, that the numbers should start to turn soon, and things like in the northern suburbs, being able to get a lot of people vaccinated very quickly, trying to get all the essential workers, essential in inverted commas. Only there's mandatory vaccination for aged care and healthcare workers, and now they've announced teachers and construction workers as sort of the people that cannot work from home. I think this is very important, and I'm hopeful that over the next few weeks that the tide will start to turn and things will start to improve. But it is going to still be a pretty bumpy road from here.
Yeah, I agree with Alan. To the first remarks, that really is not a lot of people who are doing all these demonstrations. On TV, of course, they look quite sensationalist, but it's only a few thousands. Yesterday, there were 2,000 people crashing and thrashing everything in the center of Melbourne. They are really very, very small minority. From my experience, the majority of the people they understand the need for the lockdown. Even if they don't understand, even if they start arguing about it, when you make really the points, when you explain to them why the need for it, they do understand, and they are prepared to stay there. So I think it's just a very, very small minority, and most likely there are some political aims behind all this.
Yes, Martha. Martha, okay. We lost Martha. She's somewhere in Canberra, but
I think Sam would like to speak.
Yes, Sam.
Thanks, Takis. Well, I'll quickly jump in while Martha's trying to reconnect. I had a question for Dr. Tsioutis, and that's around seasonality. As we here in Cyprus are approaching winter, of course, that changes people's behaviour and their movement patterns, but also related to vaccine hesitancy and receptiveness of people to public health messaging. I've read in the press in the last few weeks some of your comments effectively warning the community here that we may see an uptick in incidents. How else can we communicate, or can we communicate better to a sceptical group that, because of their hesitancy, is actually more vulnerable and is more likely to spread the virus? Is there a way that we can change messaging around what's potentially coming here in the next few months?
That's a difficult issue to address. Well, sorry, I might have missed some words because there was some background noise. But from what I understand, the question is mainly based on how do we increase solidarity, both to reduce vaccine hesitancy, but also to enhance compliance or self-protection during this period that is predicted to be a difficult period for Cyprus as we enter winter months. One problem, and I think also Nicolas raised it, is appropriate communication and strengthening trust to the authorities. This is an issue that we have. This is actually a game that we have lost. I think we completely lost it, and the main reason that we lost is that the authorities focused on very specific targets where they failed to include the human behavior factor, the pandemic fatigue. So, for example, when we started our vaccination program on the 27th of December, it was already nearly 1 year into the pandemic. People were tired. And let's not forget that specifically in Cyprus, we started vaccinating and 10 days later, we entered a lockdown. The second issue is that on top of that, in April, while the vaccine rollout was increasing, we entered a second lockdown. And right after that, the main communication theme was vaccinate to get your life back. So you see here all these contradictions between what messages were going out and what was actually happening. And now we're entering a new period where we have real life data, and a lot of it, that shows that actually with vaccines, you're not completely getting your life back. Of course, you're being protected. You're not going to have a severe disease. You decrease your chances multiple times. But actually, transmission is still going on. There's still more things to learn. We're probably going to need booster doses for some groups of our population. Now, these in the scientific community were issues that were very well known, or it was known that they would occur, and we didn't have the answers back then. And we still don't have answers yet on many of these, concrete answers. But as regards to communication towards the people, we weren't absolutely open. It's not a matter of sincerity, it's a matter of what you choose to publicly communicate as your message. So that's why we've lost our solidarity. And on the other hand, all these measures that we apply, and with the Safe Pass and the vaccine passports, they actually, again, further enhance categorizing our society. Now these are issues, in my opinion, because of, I think that, infection control, and Professor Cheng knows that very well, is a behavioral science. It's based on common sense and how to change behaviors, gradually change them. So we need to go back to the basics and show with honesty what lies ahead, what we don't know, what we fear, all right, without fear mongering, just what we fear and what we don't want to happen, and how we can get there. It's 2 years into the pandemic. We don't know when the end is or how it will be. So we'll need to show that we're all in this together. That's it. The authorities are the ones who make the decisions. They need to make these decisions evidence-based and well-informed decisions. We as a scientific community need to be as transparent and as objective as possible. Dr. Herodotou said that we don't need to be sentimental. We need to be very evidence-based, and the world needs to listen and make their decisions based on the one thing that we all want, is to stay safe and continue at least to have a functional daily routine. I don't know if I've covered your question.
No, you have. Thank you very much. And Tsioutis, I'll just very quickly thank all the speakers for making themselves available. Unfortunately, I have to duck out to quickly attend to something. So thanks once again to you and the board. Thanks to all of our participants from Australia and here. And I look forward to future events. So thanks very much.
Thank you, Sam. Thank you. Thank you for your support. Okay. Martha, I think you wanted to say something.
Yes, I'm sorry. I have a little problem because I'm using my iPhone, even though you said so. I would also like to thank the speakers. It was very, very interesting. I even took notes because it was so interesting, but it's very true. It is a medical condition, but at the same time, I will agree also with Dr. Herodotou that the human factor and with the other speakers, because some of you I lost during the speech, it's a very important factor. And especially when we talk about Melbourne, I mean, we all know that Melbourne is maybe the 7th or the 8th. It's been now 300 days that been on and off in lockdowns, and Sydney now 90 days, and here in Canberra now I even lost count since the 13th of August. So I think that they have to work, the medical profession, they have to work, with people who are psychologists and sociologists to make people understand religion is a factor that has to be taken into account also. Also the language, when we talk about Australia, where there are different communities, and maybe it would be a little bit difficult to explain to them the benefits you gain. And as Dr. Herodotou said at the beginning, they were saying this is good, this is not good, let's have masks, let's don't have masks. That's why we had, the anti-vaccine people. So, and I see that Cyprus is also doing very fine with the vaccination. Hopefully we are in the top in the European Union. So thank you very much, and I look forward to having any more discussion. Maybe maybe you can arrange with Sagis to have another discussion, because it's good to see how things have progressed from where we are today. Thank you all the speakers, and thank you, Sagis, and thank you all for organizing this very, very interesting forum. And thank you, Michelle, too.
Thank you.
And Cleo.
Thank you. Yes, we must not forget Cleo. She was involved from the beginning. And as I said, this discussion was between the three of us, with Nicholas and Cleo and myself. And we got it off the ground, and here we are, just finishing with it. It seems to me that from this discussion, there was a bit of a clash between science and politics, and the science and the evidence and scientists, in some ways, somehow, were more or less put aside for other reasons. As professionals and as scientists and clinicians, did you feel that throughout these 2 years that somehow you had to combat and argue with not evidence sometimes, but political issues? This is to anybody that might care to respond.
Yeah, I can probably answer that from my perspective in Australia. I mean, I think public health is always political. We don't really get exposed to it very often, but even before this, the practice of public health, we talk about the social determinants of health, the things that lie outside of personal responsibility that are responsible for people's health is political. So tobacco before this, and sugar taxes and all of this are also important. I think there's a couple of things that have come out of COVID. Obviously, there are unpalatable decisions that have had to be made by health officials and politicians, and some politicians don't want to hear that message. Luckily, that's not really happened in Australia. I think the other thing that perhaps the public haven't really seen before is it is amazing how different people looking at the same set of data, and this is including scientists looking at the same set of data, come up with different conclusions. So what we see in the public is that there's a lot of scientists arguing over things, and that actually is what normally happens in a scientific debate. It's just that normally it's not very important, or maybe only important to us as scientists. as to the topic that is being debated. But now that this is in the public sphere, scientists or the public are saying, well, one great scientist says something and another great scientist says something else, and why don't they disappear, and why don't they agree on these things, and why is there no truth? And I think Costa might have said this before about that we do need to acknowledge what we don't know and try and communicate that more clearly, but we also need to have some of these debates perhaps behind some closed doors, rather than trying to play them all out in the media, where the public will understandably become confused. I'd be interested in others' experiences on this.
Constantinos, some comment about that as well?
I absolutely agree. And I think one other issue is our media exposure that started immediately after everyone saw that science need to be aligned with politics, or maybe with the authorities anyway. There was a huge media exposure of scientists at the beginning, and it was quite difficult also for us to detach ourselves from that, to be more selective and to try to focus on the message that we wanted to give. And this, when you're focused on your science or on medicine or whatever, you're not very well used to these things, this environment, and so you get very easily carried away. And this is still going on for a lot of scientists and experts, and very esteemed experts in the field. And this exactly as Professor Cheng said, it blurs everything, and whatever we say now is put under a big magnifying lens. So it's very easy to assume that there are clashes or conflicts between us. Well, it's just a scientific debate that it was that it was what it was all those years, or all this time before. So it's actually a huge public misunderstanding that's happening. And yes, on the other hand, of course, the authorities will take and will use from our, and will apply from our suggestions what is most convenient for them, which in several occasions is not exactly what serves public health or people's health mostly, but what serves the political agenda mostly. This is something I think everybody knows now, and everybody knows that it's a different thing what we suggest, and it's a different thing what ends up being applied. Not always, but in many occasions. We're not politicians. We are not in the decision-making sector. Others have this responsibility. I think that is very clear in our democracies. And but again, unfortunately, this is often misunderstood. What I suggest doesn't mean that it's always correct, because we know that authorities need to take into account other issues as well, financial issues, other issues. So there's also things that we don't know, don't have a complete picture. So again, it's not actually a clash. It's not a clash between scientists, and it's always a clash between politics and scientists. Okay, it's what's the best decision for the people, given the circumstances.
Okay, Cleo, we have yes, Michelle.
Sorry, I've got a quick question, but also an observation that I think we've experienced a very similar problem with the climate change debate around the world, between the different scientists having their discussions online. But my question is has there been any thought about what sort of markers or indicators will be sort of the thing that progresses us from this being a pandemic to sort of an endemic, and becomes similar to like the seasonal flu jab, or that becomes part of the flu jab? Are we having that discussion yet?
I mean, I think from from an Australian point of view, I think there is the question of proportionality of interventions always is an issue. You know, is what we're doing proportionate to the risk? And at some point, closing down, you know, a whole economy and society for a small number of cases will not be proportionate, but hopefully also won't be required. So I think flu. My worry with flu is that we don't really treat flu very seriously. And thankfully we have a vaccine. It's not the best vaccine in the world, but people still do die quite a lot of flu, and we're trying to avoid that sort of question about what is an acceptable number of deaths. You know, it's still important, but if we can get everyone vaccinated, then I think it won't be proportionate to have those restrictions in place, but we will need to find other ways of protecting people, you know, and there will be the issue of boosters and all these other things that will come along. So it is going to be, we're going to have to map our way out of this, and that's what we've tried to do in Australia with the roadmap, but how it actually will turn out will be will be different, I think. I'm not sure that was a very good answer, but I think
there's a question from yes, Cleo. Someone from our audience would like to ask something. Cleo? No? Okay. Let me read it. What would make authorities?
Sorry, I was just reading the.
Okay, I couldn't hear. Yes, go ahead, please.
No, I forgot to unmute. Sorry.
Okay.
But a few questions. Yeah, we'll have the time. What would make authorities call an opening of society at the possible determination of the unvaccinated? For example, everyone in Cyprus and Australia has had a chance to be vaccinated now. Is the onus now not on the individual who choose not to be vaccinated?
I could probably take that one. That's a good question, and it's a view that a lot of people have. I think in Australia, we're probably not quite at that point yet. Not everyone certainly has had the chance to be vaccinated yet, but that point will be coming hopefully fairly soon. I think there's a couple of ways to think about that. One is that the people who are unvaccinated aren't always unvaccinated because of personal choice, or at least if they have a personal choice, they may be misinformed, or there may be barriers to them accessing vaccination. So they don't understand. And that just means that we need to redouble our efforts to make sure that they do understand what the benefits of vaccination are and understand that, you know, that they've made an informed decision. The second is that by choosing to be unvaccinated, it's not just a decision for them. It is a decision that affects everyone else as well. So if they do get sick, and particularly if they get sick in large numbers, as we would worry about if we only got to 80% or 70 or 80% vaccinated, then those numbers could still impact quite significantly on the healthcare system. They would affect the healthcare workers that have to look after them. They would impact on the medical system so that people with other diseases couldn't get treatment. So it's more than just a personal responsibility question. It's a question for all of society to try and support people to make sure they do get vaccinated. I think that's how at least I would see it.
Yes, Dr. Herodotou, you want to add something to that?
I think you might be
you're mute. Okay. Please, I didn't.
Yeah, I want to say that just I agree with Alan. It's not really a decision which affects only them, affects the whole community. So we have to find ways of persuading these people, as I said, either through education, through the media, through any sort of ways to educate them and immunize them as many as possible.
Okay. Just one final thing. I think we will end this marathon forum in about 8 minutes, I think, just to complete 2.5 hours online, which was very good, and thank you very much for that. You know about the example in Israel and what happened. You had initially a high percentage of people vaccinated, and now all of a sudden, now we have thousands of cases and these breakthroughs, as you call them scientifically. Is this because of Delta, or is it some other reason, or is it that percentage that wasn't vaccinated that affected the rest of the population? If you know the situation in Israel at all.
People in Cyprus may know, being closer to Israel. My impression is that the vaccine is still quite effective, and most of the cases occurring in the unvaccinated, Israel is slightly unusual. It has a number of subpopulations, and I understand that some communities are quite hesitant about vaccination. So my impression is that the vaccine does seem to be working in Israel. There is a little bit of concern about waning immunity to particularly the most elderly people, the most vulnerable who are vaccinated first. Perhaps the effect is starting to wear off, but it's still a very highly effective vaccine, particularly against severe disease.
Alan, isn't it like, if I may add, isn't it like the flu vaccine? In the past, we used to give the flu vaccine once a year in April for Australia and say once a year is enough. Now, the last few years, you realize that giving it in April wasn't really good enough. In September, we had another wave of increased numbers of flu vaccine or flu people infected with the flu. So now the recommendation is to give two vaccines, to give one in April and one in August or September, to avoid exactly that fact. So it's the same with this. The immunization doesn't last forever, lasts unfortunately for a short period of time. We didn't know initially how long it was going to last. That was a matter of fact because it's a new vaccine. Nobody knew exactly how long it's going to go. So now we discovered that probably lasts only 6 months or 1 year for the AstraZeneca, they say. So we have to accept that and make strategies as to how we are really going to face that.
I'm not so sure about that. So the vaccine the effectiveness does seem to wear off against infection, but against hospitalization and death, it seems to be pretty good still, even out to sort of 6 to 9 months. I think that it's a different disease than flu. The flu vaccine is not a very good vaccine. It's probably about 50% protective, which is better than nothing, but it's not highly protective against hospitalization, unlike the COVID vaccine. So I think with COVID vaccines, we're starting off at probably a better vaccine to start with, and we will need boosters. I'm not so sure that we will need them every year. It could be just a third dose will be enough. With a lot of vaccines, you do need a third dose in the second year to just cement that immune memory. And I'm a little bit hopeful that giving a third dose may give quite long-lasting protection. But I'm probably a bit optimistic there, perhaps.
I'm very optimistic.
Yes, Dr. Tsioutis.
Yeah, I agree. I think Israel is a very particular case. There was some waning immunity, perhaps because given the circumstances of the pandemic, we wanted our vaccine effectiveness to reach sterilizing immunity. But even with the 2 doses, there seems to be immune memory established pretty well. The antibody levels might wane, which means that someone is more prone to get the virus and to allow the virus to replicate even for a short period of time before his immune system kicks in. And this is actually, I think, what they saw in Israel happening. And because they saw it in many vulnerable populations and elderly, they had this huge increase of severe cases and hospitalizations. Now, after starting the boosting everyone, actually, because Israel now is giving a third dose of Pfizer vaccine to older population above the age of 12, it's being hospitalizations are at least steady. They're steadying, but we need to keep in mind that their vaccination coverage wasn't as high and still isn't as high. I mean, Europe has a much higher vaccination coverage rate, and they have their different and very particular demographics with segregation of certain minorities which are highly vaccine hesitant. So it's not actually, from this perspective, it's not a country that should be seen as a case study. There's many useful conclusions that we can make, but we need to see these data replicating in other countries before we rush to similar conclusions. So there are other countries in Europe, in the UK, that are far ahead in vaccine coverage that will start their third doses, and we'll see what happens there as well as regards to severe cases. But for now, I think that it has been shown also in several studies that there is immune memory. We have the germinal centers, we have the immune, the memory cells. It's just that if your antibody levels fall, then the reaction of your immune system to the virus, when if you're exposed to it, takes a few days to take place, and that might increase your risk of getting the disease, of having symptoms, or if you have underlying conditions or at the extremes of age, increase your chance of severe symptoms. So I'm not very sure that we're going to need like an annual vaccine for COVID. I think that it's just that we started the vaccination as soon as we had the vaccines available, and we weren't very sure about the optimal dosing scheme, as has already happened in other conditions as well. I don't know if you're aware, for example, the Johnson's vaccine. Now we had a new study coming out that said that, okay, a second dose increased vaccine effectiveness, but still that study has huge methodological problems and very small numbers to actually conclude that the JJ needs 2 doses. So there's another debate there. So there's things that still we don't know about optimizing doses in these vaccines. But I think that in a couple of years we'll know what should have been done better. But I don't think that we will need repeated vaccines, and probably not repeated for the whole population.
Can I just jump in and just although I'm not an epidemiologist, but I found very interesting the case of Israel. And that's because if you look at the vaccination rates in Israel, you'll see that obviously it started earlier than the rest of the world, and the vaccination rates were very, very high in the first few months. But Israel reached 53%, if I remember correctly, the numbers, around about March. And then it suddenly hit a wall from March until now, which is it only increased a few percentages. At the moment, it's 69% vaccinated and only about 60-something% fully vaccinated. So it's really something like Cyprus at the moment, although they've reached 50% back in March. So if you think about this, and then you think about when the Delta wave came in, when the Delta wave came in Israel, there was a lot of people, vulnerable people, who were vaccinated very, very early, were vulnerable again. So I think the issue that Israel faced was the way that they reached their flattening the curve that they shouldn't flatten, which is the vaccination curve. And if you look at the news back in March or April or May in Israel, they wanted to increase the vaccination to young people, and they were having mobile units going to bars, outside of bars, and actually inviting people to get vaccinated before they go into the bars. They used these kinds of policies, which they were never very, very efficacious. So Israel at the moment is about 60-something% fully vaccinated. But if you look at the population, and this is something that people often underestimate. Now, 65%, 66% of the population of Israel has a 9 million population. So there's still about 3 million people not vaccinated in Israel. So if you take this into account, and obviously the percentage of people who are not vaccinated, who are hospitalized or who have been infected, then you can really see that there is quite enough space for the virus to be replicated and infect people. So that's one interesting thing about Israel for me. And the other bit also is the percentage of vulnerable population. Now, I think the public is underestimating the fact that there is a lot of vulnerable people in our communities, right? So if you think about how many people are cancer patients, how many people are people who have immunological diseases, immunodeficiency, how many people have made a transplant, right? These are many people who live amongst us. So we need to transfer and communicate to the public the fact that if you're unvaccinated, as speakers also mentioned before, the choice is yours, of course, but it won't affect only you. It will affect the person next to you and the person next to you, etc., etc. So you're part of a chain of reaction. So actually, you're part of the problem. And I think this is, especially for us who have a very high percentage of vaccinations compared to other countries in Africa or in Asia. So it's difficult to explain to the 30% of people why do they need to be vaccinated if the majority of people are vaccinated. And I think this is something important as well. So for me, timing for Israel, when they hit the wall and they had very slow progress, that was very important factor for me. The number of people who are unvaccinated, not just the percentage, because I think that when we talk about percentages to the public, we sort of underestimate the numbers of unvaccinated people, right? So for Israel, at the moment, we have about 3 million people unvaccinated, which was quite a big number as a whole number, and also the number of vulnerable people. I think that's also something important to put through the public.
May I add only one little thing about that? If we have only, say, 10% of the people who are not vaccinated, and you spread this 10% of the people in the whole Victoria, then you've got really very good cover, because this 10% would be spread around and would be difficult to find each other.
Correct.
Whether if we've got the 10% like in Israel, where the 10% could be just small minority of groups segregated in small areas of Israel, then obviously you will have the problem in those small minority groups in much higher percentage.
That's a very good point. Yeah.
Okay, it's 12:35. We've been online for 2 hours and 35 minutes. I really want to thank, Dr. Alan Cheng. Thank you very much. Thank you for being with us and accepting our invitation. And of course, the time, 2.5 hours from your work is a lot of time. Thank you. Dr. Herodotou, the same. Thank you and for this discussion. Constantinos Tsioutis, thank you very much. Fellow Australian Nicholas Tsioutis, and thank you, and we gratefully appreciate your presence and your time. And I do think that this exchange is valuable, and hopefully we have done it well and in a good way. And we thank the High Commission and the University of Cyprus for supporting us and continue to supporting us. And of course, Martha, we want to involve our community in Australia, and somehow you will need to help us, and especially with our next project, which is the Australian Cyprus network of scientists, professionals, and groups, so that somehow we can develop this bond and bridges and links with Australia. Okay? Thank you very much. And hopefully see you next time.
Thank you.
Thank you again.
Thank you. Bye. Bye.
Bye-bye. Bye-bye.
Bye.
Thank you. Thank you. Thank you. Great. Thank you.
Thank you.
And broadcast.